transiently or did not improve at all, or had a later flare after the administration of IL-1. So this represents a distinct subset as compared to the one on the left. And if you compare the number, the count of active joints between two patient groups, you see that the patient on the right, the one which responded less well to IL-1 inhibition, has on average a greater number of affected joints. So this data might suggest that children with overt spread polyarthritis may respond less well to IL-1 inhibition than those with less severe polyarthritis. But there is another problem in systemic JIA, which is due to the molecular heterogeneity of these patients. You see, for instance, this study by Masaki Shimizu in Japan clearly demonstrated that based on the cytokine profile, the predominant cytokine seen in the serum of these patients, they can be divided in two subsets. One subset in which the dominant cytokine is IL-1, and this subset is more prone to the development of polyarthritis, whereas the other subset, which is highlighted by black and red and green dots, is a subset in which the cytokines of the IL-1 families, particularly IL-18, dominate, and this subset is more susceptible to develop MAS. So it can be let's say the entire spectrum of children with systemic JIA encompass two different subsets. One subset in which IL-6 blocking medication may work better, and another subset which might deserve the administration of IL-1 medication, which is because it is more likely to respond to blockade of this cytokine. Second question, what is the ideal combination of DMARDs? So let me say that there are not many studies in JA of combo therapy. In the past, many years ago, we published a study in which we suggested that the combination of cyclosporine A and methotrexate worked well and could have a steroid-sparing potential in systemic JA. But nowadays, there are not many studies. What is clear is that, as suggested by this, the adalimumab trial, is the ideal medication to be combined with biologic agents is methotrexate. You see, because methotrexate may exert a double positive favorable effect. On one side, it might have a synergistic action beside that of the biologic medication, but on the other hand, it might help prevent the production of antibodies against the biologic medication, which might inactivate or reduce the effectiveness of the biologic agents. And that the addition of methotrexate work well than the monotherapy with the biologic agents is clearly shown by the adalimumab trial, the trial which led to the registration of adalimumab for juvenile idiopathic arthritis, in which you see the frequency, the proportion of response was clearly higher for each level of improvement among children who were given methotrexate plus adalimumab than among those who received adalimumab monotherapy, and also the proportion of flare was lower in children who were given the combination therapy than in those who did not receive methotrexate. But another therapeutic intervention that can be advantageous in combination with either synthetic traditional or biologic DMARDs is the intraarticular injection of corticosteroids, because as you know, the injection of long-acting corticosteroids into the joints, which are poorly absorbed in the systemic circulation, has the advantage of delivering steroids only where it is needed, and to minimize the systemic side effects of this medication. And this may help exert the kind of bridge therapy while waiting that the biologic agents or the combination of medication may exert its effectiveness. You know, we have recently published the results of a randomized trial which was conducted by the Italian Pediatric Rheumatology Study Group, in which we found that the combination of intraarticular corticosteroid injection with methotrexate led to a higher frequency of achievement of inactive disease, and to prolong the effectiveness of the intraarticular corticosteroid injection than as compared to the arm which were given only the intraarticular corticosteroid injection. So this study showed that the addition of methotrexate to the intraarticular corticosteroid injection in children with oligoarthritis lead to a better therapeutic results. Third question, are biosimilars equivalent to biologics? Very, let's say, burning questions, because for the reason that I will highlight. So let me start reminding you the definition of biosimilars. This is a new class of medicine, these are the definition made by the European agency and the FDA, the US FDA. They are very highly similar to the approved biological medications, the originators, so-called reference medical originator biologics, and are approved provided they show or promise to show the same pharmaceutical quality, safety, and efficacy as the originator biologics. And essentially the definition are the same, with some minor differences across the two regulatory agencies. Of course, the advantage of biosimilars are less expensive, so they decrease the economic burden for the healthcare systems, but also facilitate the access to care, because these medications are being less expensive, are more affordable, or particularly in healthcare systems which are not entirely public. So, or in countries which in lower resource countries may facilitate the administration of biologic therapies to children with JAA who otherwise could not afford the administration of the originator more expensive drugs. But of course, the introduction of biosimilars in the management of children with JAA requires the positive response to these two questions. So, shall we start biosimilars already, or is better to start originators in children with JAA, or can we switch from originator to biosimilar in a patient who is stable under therapy with the originator biologics? So let me anticipate that there are no studies so far yet, perhaps a couple of abstracts at meeting, but not full articles, not trials which have addressed this question. So we need to refer to adult studies, and there are a few in adult rheumatoid arthritis. For instance, this study in rheumatoid arthritis, as compared in patients with active rheumatoid arthritis with no prior exposure to biologics, as compared etanercept at conventional regimen of 50 milligrams per week to this biologic as before. And what was seen, that essentially the effectiveness was absolutely comparable, was equal over 24 months. You see, either in terms of proportion of achievement of 20, 50, 70% ACR improvement, or decrease in the level of the disease activity score, DAS28, and also the safety of the two medications was also comparable. Regarding the second question, can we switch to a biosimilar, a patient who is already on the originator drug? This is another study which has included a broader range of diseases, inflammatory bowel diseases, rheumatoid arthritis, psoriatic arthritis, and spondyloarthropathies, but also psoriasis. And these patients who were on treatment with infliximab were randomized to either continue with infliximab or to receive this CTP13, which is a biosimilar of infliximab. And you see this forest plot. Essentially, the efficacy, the effectiveness of these two of these medications were comparable, slightly more advantage, but was close to significant only in Crohn's disease. But for all the other diseases, there were no clear advantages for infliximab or the biosimilar. So it seems that based on this study, that after switch, the biosimilar is able to maintain the same level of effectiveness as the infliximab. And also importantly, there were no differences in the, let's say, in the level of anti-drug antibodies, but also there were no disparities in the safety profile. So the two medications were tolerated equally. So, fourth question, shall small molecules, this is a new class of medication that you know well, I guess, provide a substantial therapeutic progress? That this, I refer mostly to the JAK inhibitors, which are a new class of agents which act, let's say, downstreams as compared to the traditional, the conventional biologic agents. They block the non-receptor tyrosine kinase, which are the molecule that transduce the cytokine-mediated signals via the JAK-STAT pathway. So the ultimate effect of this drug is to block the cytokine-mediated signals. So, but they block these signals at a downstream level as compared to the biologic medication. The most studied in pediatric arthritis are tofacitinib and baricitinib. There are trials ongoing. The first trial was the results of the first trial on tofacitinib in polyarticular course AA was presented at last EULAR, and I will briefly, I'm able to show you the results thanks to the kindness of Nicola Ruperto, who borrowed me these slides. There is a trial in progress on systemic IA, but I'm not yet able to present you the results of this study. The result will probably become available in the next weeks. So let's say this trial included children with active polyarticular course IA, so with any onset subtype except for active systemic IA with active systemic features, and also persistent oligoarthritis was not included, but also the other subsets were included. You see at least 5 active joints in polyarthritis and at least 3 active joints in psoriatic arthritis and ERA. All patients had to have intolerance of lack of response to one or more DMARDs. The design of the trial is the classical withdrawal trial. First stage, open label, run in. All patients were exposed to the index medication up to 4 months, 18 weeks, let's say. And then the patients were randomized, those who responded, patients who achieved at least 30% improvement, pediatric ACR improvement, were randomized to either continue on tofacitinib or to pass to placebo, and this was conducted up to week 44. Primary endpoint was met because the number of patients who, in the second part of the study, in the withdrawal part of the study, the frequency of flare is the primary endpoint. You see, the frequency of flare was higher, greater among patients with placebo than among those who were continued on tofacitinib, and you see here the survival course. Clearly, the likelihood of the proportion of patients who had flare is higher in patients who were switched to placebo. But also the evaluation of the frequency of 30, 50, 70% improvement at the end of the withdrawal phase show that tofacitinib is more effective than placebo, even though when we looked at the 30%, 70% improvement, the p-value is borderline significant, but still the difference is quite remarkable. And you see also here that on average, patients who were given tofacitinib had an improvement in functional ability as measured with the CHAC, whereas patients who were switched to placebo on average had a slightly worsening in functional capacity. So overall, this data show that tofacitinib is effective, and based on that, it will likely be approved soon for the treatment of JAA. Let's take a look at the side effects. Where the frequency of adverse events were comparable between tofacitinib and placebo groups. Patients on placebo were discontinued more commonly, around one third, mostly because of lack of effectiveness of JAA exacerbation or disease progression. There was looking at lab changes. There was a slight greater frequency of lymphopenia among children who were given tofacitinib. How can we treat resistant cases? I can't really answer this question, just can list you the possibilities that can be, let's say, the possible therapeutic option that can be chosen for children with resistant disease. Multiple intrathecal injections, switch to a biological different class, let's see, from an anti-TNF to an anti-IL-6, or from an anti-IL-6 to a, let's say, T-cell inhibitor, such as abatacept, combination of multiple synthetic and biologic DMARDs, let's say a biologic DMARD plus methotrexate plus cyclosporine A, and so on and so forth, combination of traditional biologic and JAK inhibitors, but still no data on effectiveness and safety on this approach. Rituximab has been advocated for systemic JAA with really, as far as I remember, not encouraging results, and is used in rheumatoid factor positive rheumatoid arthritis, little experience in JAA. And then there are the kind of the transplantation either with T-cell depleted autologous hematopoietic stem cells, or using even an allogeneic procedure. However, these are procedures that are usually reserved to the most desperate cases. The experience is very limited outside the UK and the Netherlands. The question remains as to whether using these strategies, which carries some potential of mortality is worthwhile in a disease which is rarely fatal. But the discussion is still open. Is personalized therapy still feasible? This is a really important question, very difficult to answer. Of course, we all would love to be able to choose the right medication or the right dosage given at the right time point for the patient that we have in front, but this is not yet possible, even though there are some initial data that are interesting. For instance, in this study for systemic JAA, it was found that genetic determinants may help to select the medication to which patients may be more likely to respond. For instance, in this group of children with systemic JAA, it was found that the expression of this IL-1RN genetic locus may guide the choice of the patients who are more likely to respond to IL-1 inhibition, because patients who were homozygous for the high expression allele for these SNPs were much more likely not to respond to anakinra. So these patients who have high expression of this allele were much less likely to benefit from anakinra therapy. You see here the frequency of the homozygotes for this allele, it was much higher among the non-responder than among patients who were responder. However, even though this study is very interesting, very sophisticated, the way the response was analyzed is really not precise. In my view, it was analyzed retrospectively, and you can read yourself how rough, how rude was the way the response was defined. I'm used to say that when we talk about precision medicine, we do not have only to think to biomarkers, genetic determinants, but also precision medicine means that we need to assess improvement response to therapy using a precise, reproducible, and comparable indicators that are reliable. And in that case, I think that precision medicine was not followed. And indeed, shortly afterwards, earlier this year, a study from this German group of investigators have shown that in their patients, this genetic determinant does not predict the response to either anakinra or canakinumab. So they did not confirm the encouraging data findings of the previous study. I think that, you know, personalized medicine, this is an editorial important by George Small and Daniel Letaya. This, I think that even though personalized medicine is attracting, is appealing, would be the best possible way to approach the treatment to our patient, we are still not yet able to implement the way. So we need to focus on abating this activity as suggested by these authors. And we also need to learn to, instead of switching from one agent to another, to use the medication that we have available, steroids, conventional and biologic medication together well by designing correct strategies rather than pursuing the use of a single agent, perhaps by switching from one to another. And clearly that the achievement of inactive disease is the most important objective that we need to pursue is clearly shown by this study made by our group, in which we have found that achievement of inactive disease in the first 5 years leads to better outcomes in terms of restricted joint count, accumulated articular damage, functional ability, or radiographic damage. The group of patients who never achieved inactive disease had poorer indicator for all these forms of damage at the 5-year evaluation. And this is the treat to target. I think we can skip this part because it's now a bit late. I think I need to conclude my talk within. Can I have 5 minutes more?
Yes, you may, Angelo. Thank you. Yes.
Because I started a bit later. But
yes,
anyway,
please.
Treat to target strategy. I think we all know this strategy. These are you can take a look at the recommendations which were formulated by the group of experts. You see, Sujata was part of this group of international pediatric rheumatologists. So they have been published. You can take a look at this paper to review the overarching principle and the single individual therapeutic recommendation. If you can't access the PDF, once more, write me an email. I will be happy to send you it. And these are the principles. I will skip. What I want to emphasize is that to implement the treat to target strategy, you need to have well-defined, reliable targets that to aim for, to reach. And there is a target which has just been published for systemic JA, thanks to a multinational study in which, if I count well, 9 Indian colleagues were involved. And this study has led to validate and to propose the first disease activity score for systemic juvenile idiopathic arthritis. It's been published in Rheumatology this week. In the last 2 minutes, what is the best approach to drug withdrawal? Another difficult question. We don't have yet recommendations of how to discontinue the medication in children who have achieved inactive disease. And we, on the other hand, we know that these patients are exposed to a very high risk of this player after discontinuation of medication. There are 2 studies that may be helpful to decide the way to treat. For instance, this is a German study. Almost 1,000 patients who discontinue methotrexate for various reasons. 1/3 of them because of the achievement of inactive disease. When they looked at the various potential predictors of subsequent flares after discontinuation of methotrexate in children who had achieved inactive disease, they found that the only parameter which was associated with the higher risk of flare was the time of continuation of methotrexate after achievement of inactive disease. Patients who were given methotrexate for a longer time were less likely to flare. So it seems that longer continuation of methotrexate may be helpful to prevent subsequent disease flare, at least 12 months. But the same was seen essentially for etanercept in this US study. You see patients with who had shorter disease duration enrollment, who were older at diagnosis, had shorter disease duration prior to inactive disease, but shorter time from onset of inactive disease to enrollment in the study. That is to so these patients had a lower likelihood for flare by eight months. So patients treated earlier were probably seems to be less likely to flare after achievement of inactive disease on etanercept. Once more, last couple of slides, it would be, we would love to have biomarkers, parameters, indicators, which might help us to identify at the time of achievement of inactive disease, those patients who are more likely or are at higher risk of experiencing flare. These are these biomarkers, this myeloid-related protein S100 were found in the past to be promising as potential to meet the goals, the goals that I have mentioned before. But in this study, it was found that none of these two versions of the myeloid-related protein, the 889 or 812, none of them could differentiate patients who experienced flare from those who had experienced continued inactive disease after discontinuation of etanercept in the previous study that I've mentioned before. And this result contradict what was found in the previous study by the same investigators. Also, another potential, let's say, way of predicting flare after inactive disease is ultrasound. This study from the group in Milano reported promising results in terms of the ability of US to predict relapse after inactive disease. But again, another previous study made by another Italian group in which I was involved did not show any difference in any capability of ultrasound to predict flare after inactive disease. In this patient group, there was even a paradoxical observation that patients with persistent inactive disease follow-up had, at the time of remission, a greater frequency of power Doppler signal, which is considered the most reliable marker of disease activity, of synovial disease activity in patients with arthritis. Final slide, just mention this study on tapering canakinumab monotherapy in children with systemic JA. It was found that canakinumab could be tapered. There was two different ways of tapering, either by dose reduction of prolongation of administration, but still you see only 1/3 of these patients were able to discontinue canakinumab to remain in inactive disease for at least 24 weeks. So the majority of the patients need to maintain canakinumab with any regimen to keep inactive disease. So it seems that for patients with CVJA, only a minority can be discontinued and maintained over time inactive disease. And with that, I am done. I apologize for the slight delay. I conclude with a memory picture of my last in-person trip to India. It was the 15th National Congress in Kolkata. And with that, I thank you very much for your attention.
Thank you very much, Angelo. That was a wonderful covering of a very difficult topic that we chose for you. That was absolutely wonderful. So I think what we may do, Manjari, if you agree, is we move on to the panel And once we complete the panel, then we take the question and answers together. So can I encourage everybody to post the questions on the chat, please? So if I could start off with the first question, I would like to direct to Professor Surjit Singh. So Surjit, in our country, when we start biologics for our patients, because we have such a high burden of infectious diseases, we tend to be quite systematic in looking for any risk factors for the patients before we are confident to start the biologics. So in your unit, what test do you conduct before you start the patient on a biologic response modifier? And second question related to that is, if you find your patient has latent tuberculosis, which drugs would you use, and after how much time would you then commence the biologic?
Uh, that's a difficult question, but normally we would do a tuberculin test and a chest X-ray. We do not do a CT scan routinely. We only do a tuberculin test and a chest X-ray. And if the two are negative, then we generally uh, uh, don't do anything else. But if there is some evidence of latent tuberculosis, and these either on tuberculin test or on chest X-ray, we would start anti-tubercular therapy, give it for 3 months, and then consider a trial of biologics.
And in your unit today, would you use only INH or a combination of INH and rifampicin?
We prefer using INH and rifampicin.
Okay, thank you for that, Surjit. So, Professor Surjit works in PGI in Chandigarh, and they see patients from all walks of life there. And there are many, many children who come who are not very affording. So, Raju, in your practice, how would you screen a patient? So, Dr. Surjit said that they would do a Montu and a chest X-ray. In your unit, what would you screen the patient with? Dr. Khubchandani, please. Dr. Khubchandani, can you please unmute yourself?
So, firstly, Sujata, it feels very awkward if you call me Dr. Kupchandani because you normally call me names. So it's all right, but I'll accept that for the moment.
I'm on my best behavior.
Yes. So I would agree with Surjit that a Manto and a chest X-ray. But if I have a small element of doubt, I would extend it with a CT scan. And we additionally routinely screen our patients for hepatitis B and hepatitis C before we start any immunosuppression.
What about
And
an HIV? Sorry, Raju, do you do an
also,
HIV?
so we do a triple H basically, yes. And but triple H, Mantu and chest X-ray is our routine protocol. And as I said, with a CT chest, because God forbid if something goes wrong along the way, then you're going to be spending much, much more. So I find it much wiser to do a CT and very clear that way.
And Angelo, if you could ask for your comment, in Italy, when you start a patient on a biologic, do you consider screening all children for tuberculosis or only the ones you deem at high risk?
No, I should say when we start any biologic medication, we screen all children by Mantoux test, or those more at risk, perhaps we can also do, or in alternative, do the how you call it?
Quantiferon gold?
Excuse me?
The quantiferon
The
test?
quantiferon, sorry, I forget the quantiferon test. We
Sujata,
almost never request chest X-ray or CT scan unless there is really a child at very high risk.
Sujata, one important point is that we always check the vaccination status and complete the varicella vaccine for sure.
Sure. Sure, certainly. No, this question was specifically for tuberculosis. That's very interesting. So, in our unit, we would tend to do a Montu and a quantiferon gold, in addition to a chest x ray and an ultrasound abdomen for the TB screening. And we looked at our data, and we have a bunch of children who are only quantiferon gold positive and Montu negative, and vice versa. That we don't find the concordance 100% between the two. So if we find anything which is positive, then we would go ahead and do a CT scan. Early on, we were quite liberal with doing CT scans, but as we've become more confident, we have backed off on that. So I think with that, we'll move to the next question, and I'll ask Manjari to take over.
Yeah, sure. Thank you. So my next question is to Dr. Priyankar, and if you could just unmute yourself, thanks. So this is in continuation with the screening of TB. What the previous question dealt with the screening of a patient initially, and this question is that how often would you repeat a TB screen on a patient who's on a long-term biologic? So your patient is on a TNF inhibitor for say 2 years, 3 years. So how often would you repeat? Would you repeat? Would you not repeat? And if you would repeat, then what tests would you use to repeat?
Usually we do not repeat. We just tell them that, and that is very, we tell them and explain in details while we start the therapy, and that is also reinforced when the periodic come for checkup, that if anyone in the family develops tuberculosis, if there's any possibility of an exposure to tuberculosis, then they should immediately get back to us. So they should immediately inform us, and that is what we usually do. We do not routinely screen for tuberculosis subsequently after starting therapy.
Okay, great. So would anybody else like to answer, or would you do anything different in your units? Anybody from the panel could answer. Yeah, Dr. Satish, tell me.
Yeah, so this most of our children before start biologics, they do definitely receive some amount of steroids for some time. Steroids will seriously affect the Manto test reading. So in our unit, we routinely do IGRA test, quantiferon gold, before you start on biologics, because of this Manto going to be negative because they are already immunocompromised. Thank you.
No, but would you also repeat the screening on, so
No.
especially if a child is on adalimumab or infliximab, which we know that can give rise to more of TB incidents, and we are a high endemic country. So especially not on etanercept perhaps, but on adalimumab, and if you're giving adalimumab for uveitis, for example, which is long-term, 2 years, 3 years, 5 years, we don't know the end to it. So would you screen or re-screen these children at any point if they are asymptomatic?
As Priyanka said, routinely no, unless they develop any symptoms, lymph nodes, pneumonias, weight loss, unexplained. If you are suspecting any clinical symptoms, routinely no.
Okay. Great.
So can I ask Satish, the corticosteroids are going to affect the IGRA test also. I mean, so have you got any data to suggest that the corticosteroids only affect the MON2 test and do not affect the IGRA?
I'm not sure, ma'am. Immunological aspect of, but whatever I'm reading compared to Manto, because the elicitation will be very less compared to IGRA test.
Yes.
So that's interesting. So in our unit, we have seen that we have a MON2 conversion in 7% of our patients, and we are quite rigorous about repeating the screening for tuberculosis. We try to do it after 1 year, but sometimes we do get delayed, and within 12 to 18 months, we are quite particular about doing a re-screening for the child for MON2, and we do have secondary converters. We do. And I think as far as the adult world is concerned, they do suggest that the patient should be screened if they are on long-term biologics.
Is it only related to TNF alpha inhibitors, or would you do it even with tocilizumab too?
It's predominantly for anti-TNF agents because they reduce the granuloma formation. So it's predominantly for anti-TNF agents. Angelo, in your practice, when a child is on a biologic for many years, would you go ahead and re-screen for tuberculosis?
No. In general, the prevalence of tuberculosis in Italy is very low. So we don't screen unless there is any potential evidence for an infection. If the child has fever, has low-grade fever, persistent low-grade fever, or weight loss. But I should say that in many years that we treat patients with biologics, we have perhaps seen 1 or 2 cases of tuberculosis occurring over time. So we don't screen regularly.
Not regularly. Okay, that's interesting. If we can move on to the next question. So Satish, you heard Angelo telling us today that there is data to show that there's not much of a difference between the biosimilar and the originator. So would you agree with Angelo? And if you have a choice in your practice, would you choose an originator over a biosimilar? And what defines the data points that you study as you decide which patient gets an originator and which one a biosimilar?
So as Angelo rightly said, there is no big difference between these two things. So what we do in our unit is whenever you, because nowadays we have only this biosimilar is only there for etanercept and infliximab. And most of us, we don't use infliximab routinely in your JA practice anymore nowadays. And the only issue is with the etanercept. And obviously rituximab, which is not much used in JA. So apart from etanercept, all the others are, and adalimumab, we all know that in India, we don't have the original at all. Humira is not available at all. So whatever is available is all are biosimilars. And if you take the price is the one which is a deciding factor a lot. So I usually tell the parents the price of the originator and the biosimilar. Then the price, you, as of all of you know, the price difference is not very huge. If you take etanercept, is about 3,000 rupees. If you take the etanercept biosimilar, it is about 2.2 to 2.5. So 500 rupees per vial. That's the difference we are talking about the originator. And so usually we discuss with the parents. If the parents believe that they can afford, I prefer to go for bio originator. And if the parent says, no, the money is a big issue player, then I go to the biosimilar. That's what usually decides.
Okay, thank you for that. So I think it's really an economic decision, and you prefer to use an originator wherever you can.
Yes.
But in our country, we don't have many originators. So Angelo, for example, we don't have the originator of adalimumab.
We have nowadays we have originators for etanercept and adalimumab too. And I should say that that our health authorities and also hospital authorities are now forcing us to use to always use the biosimilar for economic, essentially only for economical reasons. So we have many biosimilars for etanercept, but also for adalimumab. Not
so
yet.
Angelo, okay. So Angelo, if I could pose one question to you before we move ahead with the panel. If you have a young child who is ANA positive, has not developed uveitis and who needs an anti-TNF agent, would you choose etanercept or adalimumab?
This is a very you ask always challenging questions, I see. Sujata. So it's difficult. So I think that our impression in general is that etanercept works better than adalimumab for arthritis. Said that, if a child has mild arthritis, even polyarthritis, resistant to methotrexate and ANA positive, we might choose adalimumab. But if a child has severe arthritis, we use etanercept. I don't have really the impression that etanercept increases the risk or the frequency of uveitis in our. In Italy, ANA positive patients represent 85% of the entire. I don't know if you have taken a look of our EPOCA study, that was published last year. In Italy, or our studies in general, we have 80 to 85% of the children who have ANA positive JA who have disease onset before 3 years of age. And in most of them, we use etanercept, but we don't have the impression that etanercept really increases the risk of uveitis.
So, Angelo, do you have patients who have developed new onset uveitis on a combination of methotrexate and etanercept?
We have, but you never know that if this was part of the natural history disease, so this would have happened anyway, or whether this was could be due to the kind of side effect of etanercept. In general, if you combine with methotrexate, theoretically, this would decrease the risk, the potential risk of occurrence of uveitis if this was due to etanercept. But so we don't have sufficiently strong data. We would need a kind of control trial which in children with ANA positive JA compares etanercept and adalimumab in terms of risk of uveitis. but we don't have yet such trial. We don't have any head-to-head trial with biologics in GIA so far.
Okay, Manjari, do you want to continue?
But it's a limitation.
20 minutes.
Yeah. So, thank you for that. So my next question is to Dr. Mahesh. Dr. Mahesh, we see enthesitis-related arthritis as the most common subcategory in our country. And when we know that some of the genesis of the disease, the ERA, especially this subcategory is from the GI tract, the gut. So if you have to choose a TNF-alpha inhibitor in a patient with ERA, do you tend to veer more towards adalimumab or a MAB rather than a SEPT, or would you use a SEPT nevertheless? So what would be your preference in a ERA patient, a MAB or a SEPT?
Yeah, as far as in my practice is concerned, actually I would prefer a MAB compared to a SEPT. And the reason is actually more than personal experience. It's because what we read on the from the literature. One thing is actually we know that etanercept, I mean, though some of them say it cannot cause uveitis, we know that some ERA patients can have uveitis, and so in that way it may be contraindicated for the usage of etanercept in ERA. And another thing is we also know that there's some sort of subclinical inflammation in these patients in the gut in ERA, and there is also some reported there's reported literature regarding the incidence of IBD in patients treated with etanercept. So I have sort of a lot of hesitation in using etanercept in ERA. Before the availability of adalimumab, I have used etanercept. That's before 2013 and so. A couple of patients, none of them had problems actually. And as far as adalimumab is concerned, I think we know that actually it is useful in uveitis and in IB, in the treatment of IBD. And moreover, the convenience of using it is only once in 15 days subcutaneous injection. And the cost also compared to other medicines, it's not different. It's only a few hundred rupees. So in that way, I prefer adalimumab compared to other drugs. And infliximab, again, because of the problem with that the child needs to come into the hospital every time for IV intravenous administration, the cost of the admission, the cost of the medicines, all that goes up. So I don't prefer infliximab. So that the reason is for adalimumab is the convenience and the other reasons that we can actually advantages of giving adalimumab, the usage of for uveitis and IBD. That's the reason.
So Surjit, in your practice, Dr. Surjit, in your practice, would you give preference to a SEPT or a MAB for an enthesitis-related arthritis patient? Dr. Surjit, yeah?
I don't think he's there.
Yeah, we would generally use adalimumab.
Okay, that's interesting. Yeah. So Manjari, you want to carry on?
I saw at least 2 cases of children with arthritis treated with golimumab, which is kind of, let's say, human antibodies against TNF, who developed ulcerative colitis.
Right, but I think Simponi has not really taken off very well in children. Otherwise, it's a very good thing, just a once a month injection. So to continue my question, Dr. Mahesh, have you ever used anti-IL-17 in your practice, and what are your thoughts about it?
No, I haven't used anti-IL-17. I haven't used.
And do you do any endoscopy in children if you're suspecting IBD, if they don't have any clinical symptoms, so to say?
Even if they don't have clinical symptoms, actually, there's any mild symptom related to the gut. Sometimes there might be just mild, some loss of weight in spite of having a good appetite. And sometimes among the tests, we see a very low serum albumin in these children. And that actually is an indicator, we used as an indication to do a scopy in such children. And we have found a couple of cases with IBD. They're completely asymptomatic otherwise, no GAT symptoms.
So Amita, you have published so much in the area of enthesitis-related arthritis. Do you look at the fecal calprotectin in the patients as you begin to treat these children to decide if you want to give a biologic, which one should you give? Because we know that children can have just 1 or 2 joints in enthesitis-related arthritis and yet have an ESR between 80 to 100. which is not really seen in children, for example, with oligo-GI as a commonality. But in ERA patients, very often we see very high ESRs.
Yeah, so so our situation is very different. So our patients, very few of our patients actually can afford biologics. So our suspicion is higher for IBD when we have, as Mahesh said, if patient is losing weight, if patient has symptoms, if patient has low albumin, and also anemia out of proportion to the degree of inflammation. So these are the features we take for screening for inflammatory bowel disease. And in the recent past, we have also been using fecal calprotectin. It's a good marker, but it's not a great marker. It can be elevated in many other conditions. It's not only inflammatory bowel disease. The patient has had a diarrhea in the previous 2 days, you can have it elevated. So we haven't used it so much, but our adult physicians use it a lot as a marker for subclinical inflammatory bowel disease. So we are planning to do a study to see how good it is in our situation, a fecal calprotectin as a marker for subclinical gut inflammation.
Raju had something to contribute. Yes, Raju?
Yeah. So actually, I was just going to supplement what Amita said, that there's a peculiar scenario that the fecal calprotectin, at least commercially, is reasonably expensive. And then one believes that you do the fecal calprotectin and subsequently do a colonoscopy. You may as well as put the money in a colonoscopy because they are resource challenged anyways. And I prefer using fecal calprotectin more as a follow-up marker if initially elevated. Then you know that it prevents the need for a repeat scopy and tells you what degree of remission he is in if it was elevated earlier.
Thank you for that, Raju. So, Angelo, I don't think we have ever seen any data that talks about the differential efficacy of etanercept versus adalimumab in children with enthesitis-related arthritis. Though the commonality, at least in our part of the world, seems to be a preference for a MAB versus a CEP because the science tells us that the disease is definitely focused somewhere in the gut, even though the child may not have overt features of inflammatory bowel disease. What is your opinion on that?
You mean regarding? I think that yeah, we also tend to prefer adalimumab for enthesitis-related arthritis patients because we have seen a number of them who developed IBD. So it occurs. So I mean, this patient we tend in general to prefer sulfasalazine and adalimumab. There was a question on IL-17. This is a promising biologic agent for children with ERA or spondyloarthropathies in general. There is a trial ongoing, which hopefully will be completed soon, and the result will be available next year.
Okay, thank you for that.
But in general, I agree that children with spondyloarthropathies, but also patients with CRMO, we have seen some of them, may be monitored carefully with calprotectin, perhaps, because they may develop over time IBD.
Thank you. So we'll move to the next question. So Dr. Anand, when an anti-TNF agent fails for your patient, would you switch to a biologic response modifier in the same class, or would you switch the class of biologic you are using?
I think Angelo has mentioned this in his talk, that if you are having a failure of one of the biological response modifier, commonly used one is TNF alpha inhibitor, it would be better to switch class. So if you are having unless, of course, there is one caveat. If the response to the TNF alpha blocker was good initially, and subsequently there was a dip in response, most probably related to the monoclonal and to the antibodies against the agent, then maybe you would use, say, if you're using a CEPT, you would use a MAB, or if you're using a MAB, you would use a CEPT. Otherwise, as Angelo did mention, it would be prudent to switch over to something like using a IL-6 blockade or a T cell blocker like abatacept. That's what the current recommendation says. Even the ACR recommendation of 2019 article by Sarah Ringgold does mention the same.
So, Angela, would you also distinguish between a primary non-responder and a child who has a secondary failure to the anti-TNF after a prolonged period of time?
So can you repeat, please? Say if I can.
So, if a patient is on an anti-TNF agent and does not respond, would you switch in another drug of the same class,
Okay.
or would you switch the class?
No, this is another difficult question because we only have anecdotal data to base our choices. Etanercept and adalimumab are the same class of medication of the same class, but they are completely different. I mean, the structure is completely different. One is a, let's say, engineered molecule. Another one is a monoclonal antibody. So it can be, I think sometimes we switch from etanercept to adalimumab or vice versa. I should say that more common switch from etanercept to adalimumab is done because of the occurrence of uveitis or worsening of uveitis, whereas the switch from adalimumab to etanercept is mostly due to worsening of arthritis or flare of arthritis.
Right.
So in general, we tend to, our first choice is to switch from these two agents within the anti-TNF medication. Then, if there is a failure of both of them, we nowadays consider first line IL-6 inhibitors, tocilizumab or sarilumab, even though in the past, particularly for older children, we have also switched etanercept or adalimumab to golimumab.
Right.
With equivocal results. I can't generalize because they were very few.
Okay. Sharath, last comment from you, then we'll move on to the next question. Yeah, Sharath?
Yeah, I think I just want to highlight what Dr. Angelo said, that it's important about the subtype. So in enthesitis-related arthritis, you are limited to anti-TNF, but in polyarticular, I think it works more economic sense. Like the cost effectiveness is more if you switch to a different mode of action. At least that's what I do based on literature and adult data.
Okay, thank you so much. Manjari, you want to continue, please?
And next question is to Dr. Raju. So in a patient, when methotrexate fails and the patient cannot afford a biologic, then what is your preferred combination choice for a combination DMARDs in the conventional synthetic DMARDs?
So, Manjari, thank you for asking this, which has a very burning problem since the last 15 years in my mind. Let me just lay a little backdrop and take off from what Satish mentioned about the dropping costs of infliximab and etanercept. However, let us make it very clear that IL-1 is not available to us. And the availability of subcutaneous tocilizumab has not reduced cost of treatment to the patient by virtue of removing hospitalization, etc. Possibly it's slightly higher. Now we are playing a game which is very long, and it's not only initiating biological therapy, but also sustaining biological therapy. We have a cost issue. Our per capita income is $1,000 and our insurance penetration is less than 10%.
Really?
In this scenario, all guidelines, recommendations are all written for west of the Suez Canal. There is no Afro-Latin American, Asian idea about how to deal with this. Now, let me just tell you what other options exist. The MTX cyclosporin option of Angelo is something that I have tried in 4 patients. I think his original series, if I remember right, had described 16 patients.
Probably, yeah.
Yes, and I have used it in 3 or 4, particularly those who have followed macrophage activation syndrome in SGI. My second is a very, very It's one of my favorite drugs. And I think it's like in cricket, when you have two excellent wicket keepers on the scene, one gets ignored and the other guy plays all the innings, and that is leflunomide. I think it's cheap, it's oral, and it's safe. But for some reason, it has always flown below the radar. So what I often do is I either swap methotrexate for leflunomide or I add leflunomide. And there is a paper written by Pranav and me, published in Clinical and Experimental Rheumatology in 2016. The third option, which is really one of my favorites, is thalidomide. I again have a small case series written on thalidomide published. And just now we have 24 patients on our file where we are analyzing their data. Adverse effects with thalidomide have been a beginnings of a peripheral neuropathy in one and thrombocytopenia in one. Otherwise, no other monitoring is required. You start it in a patient where you can clearly ask questions about tingling and numbness. Nothing else is required. It's pretty cheap. So I believe that the pharmaceutical industry is never going to be interested in doing a trial on a low cost molecule, which the penetration is not very high. These kind of studies will have to come only by investigator initiation from such countries. And I'm glad that Angelo, who's now the forthcoming president of press, is listening to this. Maybe he would think about some trials in this area.
Thank you for that, Raju. I don't want to overstep the time. So we're just going to run through the next few questions. Sharath. So Sharath is one of our young pediatric rheumatologists who's extremely well read and very versatile with his hands. And Sharath uses ultrasound in a very nimble way in his clinic. So, how do you use it in your day to day practice? Do you find it helpful? Or do you want to convince the naysayers that there is something very exciting about using the ultrasound, or should we abandon it? You may have attended one of the debates that took place during the APLAR in Chennai, where we had two rooms where we had senior rheumatologists from UK and from Europe who virtually came to blows with one another about the role of ultrasound, yay or nay. What is your take on it, Sharath?
So ultrasound is a tool, and definitely it is one of the. It's another tool that we can use, and it is an important tool that we have to use in the future. It definitely adds to the amount of information that we get in the clinic. So many times we are uncertain. To take the example of transient synovitis itself, to get a blood test done, to get back the CRP, instead of that, you can just put a probe, and it's so user-friendly. The patient tolerates the probe. Even small children tolerate the probe very well. They feel it's a plaything, and you can immediately get whether it is a septic arthritis or whether it's the transient synovitis. In addition to that, we have good data to show that many, compared to clinical examination, ultrasound that we do need to use frequently in the clinic. I use it frequently in the clinic, especially when I have any doubt with respect to whether any joint is inflamed. There are certain joints, for example, the hip joints, the mid-tarsal joints, which might be a bit confusing whether it is enthesitis or whether it's subtalar synovitis or whether it's posterior calcaneal bursitis. So these can get clarified very easily on the ultrasound. So this is how I use the ultrasound in day-to-day clinic.
So thank you for that, Sharath. And I think two important points I would like to raise. And we have Clara from Angelo's unit who leads imaging in pediatric rheumatology. And I think two very interesting points that we've picked up, because we also use the ultrasound in our practice on a regular basis. One is the site of inflammation, even for the wrist. It's so amazing that what you think is a radiocarpal joint is actually one of the extensor tendon compartments.
Yeah.
And that makes a huge difference as to what you should inject, and whether you should actually inject or you need systemic therapy. And the other very fascinating thing we have begun to find is a bicipital tenosynovitis in the child with systemic arthritis. Sharat, do you see this in your practice? That you have a child who's febrile with an evanescent rash, you clinically examine, you're not finding a joint, but you put the probe on the biceps and behold, there's a significant bicipital tenosynovitis. Do you see
So
that, Sharat?
in one child in whom I did screen because she had significant pain and swelling in the shoulder, I did see it in the other shoulder, which was asymptomatic. Yes, she did have bicipital tenosynovitis, but I have not been doing it routinely. Now that you mentioned it, I got reminded of that one patient. But it's probably that would be a very interesting finding. Probably I should screen routinely my
So
patients and get back to you.
I would say to all the youngsters in this who are attending the webinar today, when you get older, when you cross 50, it's really not easy to learn new skills. But when you're younger and you pick it up, it becomes like learning a new language, and it's a remarkable tool to have in your hand. And I think it's absolutely fascinating. Angelo, I understand that your unit is also heavily biased towards ultrasound.
Yeah, you are right. We are biased, but I think we should not overemphasize the role of ultrasound. So the clinical assessment always comes first. In my experience and view, ultrasound is fundamental for three main indications in, let's say, established JIA. One is in the wrist, as you said, to identify well where is the site of involvement, if a joint or a tendon. Is fundamental for the hip, of course, and also for the ankle and midfoot, because these are areas in which there are many joints and many different tendons. And as for the wrist, a precise location of the inflammation is fundamental to drive the indication of joint injections. This is for these three joints. Outside of these three joints, I don't see really many indications, unless you want to use it for research.
Another thing, Sharat, would you say is that, when you have children who are hypermobile and they present with systemic arthritis, it is remarkable as to how many patients we would miss for hip disease on looking at the internal rotation, the external rotation, asking the child to squat, getting the child prone, looking at the extension of the hip, it's all normal. But you put the probe and you see a bulging effusion. And that could, to my mind, be one reason why children with systemic arthritis have bad outcomes with the hips, because really clinical examination may not be enough to understand that your patient requires more treatment.
Yes,
Amita,
that
in
has
your
been.
center also you're using ultrasound now regularly?
We do a lot of ultrasounds, but as Angelo said, most of our ultrasounds are either for diagnosis, to find out what is the site of inflammation, and the second is for intra-articular injections. So we are not doing regularly for, like what you said, for systemic onset JIA to look for bicipital tenosynovitis or for something else. So we generally use it for, as Angelo said, for wrist, foot, hip joint. So these are joints sometimes very difficult to examine, or some shoulder joints. Like sometimes you're not able to figure out, does the patient have shoulder joint arthritis or is it something outside the joint, and you're not 100% sure, and then you look at the ultrasound.
Okay,
So
I think we are running a, yeah, sorry, Sharat, yeah.
So I take in the patient for these specific indications, but out of curiosity, when I do, I generally, if I'm not too busy, I generally do screen some the other joints as well, asymptomatic, and I have come across the situation which you just mentioned. And if you see the data, sound seems to be better at picking up inflamed joints compared to clinical examination.
Thank you for that, Sharat. So, Manjri, you want to proceed? I'm sorry we've overrun. Can we have 5 minutes indulgence to complete the meeting? We have 2 questions more. Yeah, Manjri, do you want to carry on, please?
Yeah. Our next question is to Amita ma'am. Ma'am, this is about MRP 814 and its role in the clinic. So do you think that it's practical and useful as a biomarker to use MRP 814 to be used in the clinic? And if you would use it, where all would you use it?
So I would have a one-word answer: no. At present, it's not useful in clinic. But because it doesn't have the adequate sensitivity and the specificity to either predict flare or to be a measure of response to treatment. So, and the main three things are there, that the values, the cutoffs are different for different studies. Then if you see data from India, our baseline values of MRP 814 are much higher than what has been reported from the West, probably because we have a lot of subclinical GI infections. And the assay is not that easily available. It's mostly a plate thing, a batch-based assay. So you cannot apply it same day like ESR and CRP, which you can get off the shelf within few hours. So it's not for the clinic.
Angelo, do you use it in your practice? Thank you, Manjari. Angelo, do you use that in your practice?
So this is myeloid-related protein? No, we don't.
No,
we don't. I showed you so they were very promising as biomarkers based on the Printos trial, which was made on patients in remission with methotrexate, in which it seemed that patients who had a value above a certain threshold could be more likely to experience flare. But the recent study that I mentioned in my talk in some way didn't confirm the value. So it's, I think there is and also I don't know if the commercial kits are comparable to the kits that are in the hand of our friends in Münster. So that there are still many studies to make before including these biomarkers in clinical practice. Very interesting, but not yet let's say, reliable enough in my view.
Thank you for that. And now we have saved the best for the last. And Suma, thank you so much for your patience. I'm sorry we've come to you last. So the question for you is, as you wean a patient off a combination of methotrexate and a biologic response modifier, which one would you wean off first and why?
Well, I mean, economics and science kind of dictate this answer. And definitely in our patients, biologics are the first one tends to wean down. And I think you want to get the patient into remission first. You want to make sure the remission is, after you weaned and stopped all steroids. And then once you've had them in a stable remission for a while, I would start weaning off the biologic first. And my thing would be usually to increase the gap between doses and slowly come and take the biologic off. And then after that, only think about weaning the methotrexate. Essentially, it comes down to whether you can keep the patient in remission on methotrexate alone and then wean them off the methotrexate. It's going to be very, very difficult and, very difficult to convince a patient to wean the methotrexate first and keep the biologic going unless they had kind of unlimited access to, to support for the biologic. Interestingly, there's actually a study going on this. It's started recruiting. It's, I think it's it started recruiting in 2016 and it's not over yet. I don't know at what point the study is now. So they're looking at the same thing about the process of weaning on a patient who's got a combination of biologics and DMARDs. And hopefully that's also going to yield more light into this.
Yeah, thank you for that, Suma. So see, Angelo, regardless of what the science may say, and the science says that if you wean the methotrexate first and then the biologic, the risk of relapse is 16% vis-a-vis if you do it the other way around. If you take the biologic off first and then the methotrexate, the relapse risk is 64%. But see, science is cannot be translated into practicality in most parts of the world. What is your practice, Angelo?
No, what I can say is that we have a trial ongoing in Italy, which is led by Alessandro Consolaro in my group, in which we aim to compare a step up versus a step down strategy. So step up means start slowly and then increase. In both arms, the endpoint is inactive disease, complete remission. So step up, start slow and increase if the target is not reached. Step down, it starts with a strong intervention, biologic plus methotrexate plus steroids, and then taper biologic first once remission is achieved. But this study is still ongoing, so we don't know yet. I
So in your
think
practice right now, Angelo, what would you do? If a patient is stable on a combination of both, which one would you take away first?
what we have always aimed for in the last at least years is for early remission, because it is clear that the earlier you achieve remission, the better is the outcome of the patient. So it depends on the subset. We use very much joint injection in oligoarthritis, but also in polyarthritis as induction therapy, and then methotrexate first. But then we have a low level of tolerance for adding biologic. So if remission is not achieved or is not maintained over a short term, we add very early biologic therapy. So we don't rarely use biologics first in oligo, poly, or ERA, with the exception of ERA with severe sacroiliitis, I should say. We use a bit more in systemic JA, because in systemic JA, intrathecal injections, they work, but the effect is short-lived.
So
No, but my suggestion is the philosophy of the treat to target. As I said, the target and the strategy is more important than the
And the
agent.
drug you use. I agree. I agree. So thank you for that. We have several comments on the chat. I think we've managed to address most of them through this panel discussion. And I think we'll draw it to a close. And Angelo, thank you so much for your time this evening. I think we've all enjoyed it. It's been a great learning experience. And thank you to all our wonderful panelists and to the very attentive audience. And I'm sorry we can't take any further questions, but we've crossed 7:30, so I don't want to outlive our welcome, because we seek your indulgence in a month for the annual conference as well. So any closing comments?
For me, it's only 4 p.m., so I'm not. It's still daylight.
It's still a little bit. It's a Sunday evening for you, so we won't keep you back.
Yeah, that's it. I would join my wife and my daughter was at the beach.
That's really important. Thank you so much.
Okay.
And stay safe.
Thank
Stay
you.
safe, everybody.
Okay. Thank you very much. Great
Thank
pleasure.
you so much.
Thank you.
Bye
Bye.
bye. Bye bye.
Bye-bye. Thank you very
Anand,
much.
thank you so much for facilitating this. Thank you so much. Good night.
Thank you. Thank you so
Good
much.
night.
Bye,
Bye bye.
Angelo. Bye, Angelo. Bye.
Bye.
Bye bye. Good night. Bye.
Bye, everybody.